Hello, everyone. Let's do a quick sound check. If you can hear me, please type yes in the chat box. All right. Looks like a lot of people can hear me. So let's take care of a little bit of housekeeping information before we dig into the substance of this webinar. If you have any questions, comments, or concerns about technical or other issues, please go ahead and enter them in the chat box that you just used for the sound check. And if you have any questions for the presenters about their presentation, please put them in the Q&A box, which is separate from the chat. And the Q&A box is just a box that has a Q on it. And then the chat has a little speech bubble. And my screen, they're at the top, but I know sometimes they can also be at the bottom of the screen. And then here are some answers to some commonly asked questions. Yes, we are recording the webinar. And the recording will be available on the CADCA website following the webinar. And yes, I will send out a copy of the slides following the webinar. And yes, CADCA provides a letter of participation to attendees who request one. And I will provide more details about how to request one at the end of this webinar. Welcome to everyone to the latest installment of CADCA's Research into Action webinar series. I'm Carolina Duth, and I'm a member of CADCA's Evaluation and Research team. If you haven't previously participated in one of our Research into Action webinars, the purpose of this webinar series is to introduce coalition members and substance misuse preventionists to current and relevant research being conducted in the substance use and community coalition fields. I'm joined for this installment by Dr. Robert DuPont, Dr. Caroline DuPont, and Dr. Bertha Madras. They are authors of the study, Drug Use Among Youth, National Survey Data Support a Common Liability of All Drug Use, published in 2018 in the journal Preventative Medicine, and they will discuss youth polysubstance use. If anyone is interested in reading their article, I will be distributing electronic copies following the webinar. And now I'd like to introduce our presenters, Dr. Robert DuPont, Dr. Caroline DuPont, and Dr. Bertha Madras. For 50 years, Robert L. DuPont, MD, has been a leader in drug abuse prevention and treatment. He was the first director of the U.S. National Institute on Drug Abuse from 1973 to 1978, and the second White House drug chief from 1973 to 1977. From 1968 to 1970, he was Director of Community Services for the District of Columbia Department of Corrections. From 1970 to 1973, he served as Administrator of the District of Columbia Narcotics Treatment Administration. In 1978, he became the founding president of the Institute for Behavior and Health, Inc., a nonprofit research and policy organization that identifies and promotes powerful new ideas to reduce drug use and addiction. A graduate of Emory University, Dr. DuPont received a medical doctor degree in 1963 from Harvard Medical School. He completed his psychiatric training at Harvard and the National Institutes of Health in Bethesda, Maryland. Dr. DuPont maintains an active practice of psychiatry, specializing in addiction and the anxiety disorders, and has been clinical professor of psychiatry at the Georgetown University School of Medicine since 1980. He is the author of Chemical Slavery, Understanding Addiction and Stopping the Drug Epidemic, published in 2018. Dr. Madras is a professor of psychobiology at Harvard Medical School, based at McLean Hospital and cross-appointed at the Massachusetts General Hospital. She directs the Laboratory of Addiction Neurobiology at McLean Hospital, where she has focused on translational research, neurobiology of therapeutic and addictive substances, brain imaging, and medications development. Dr. Madras has served as Deputy Director for Demand Reduction in the White House Office of National Drug Control Policy, a presidential appointment confirmed unanimously by the U.S. Senate. In 2016, she served as a panelist at the Vatican Pontifical Academy of Sciences, Narcotics, Problems and Solutions of this Global Issue, and in 2017 was appointed by President Trump to a 6-member commission on combating drug addiction and the opioid crisis. She is recipient of an NIH Merit Award, NIDA Public Service Award, American Academy of Addiction Psychiatry Founders Award, and others. In her role as Vice President of the Institute for Behavioral Health, Inc., Caroline DuPont, MD, focused on the areas of addiction treatment and prevention. She maintains a private practice specializing in anxiety and addiction. Dr. DuPont received her medical doctorate from the University of Texas Health Sciences Center, Houston, and completed her training at Johns Hopkins Hospital, Baltimore, where for years she held an appointment on the clinical faculty of psychiatry. She is board certified by the American Board of Psychiatry and Neurology and by the American Board of Addiction Medicine. She's the co-author of numerous publications and several book chapters on anxiety and addiction. Now I'll turn it over to Dr. Robert DuPont, Dr. Caroline DuPont, and Dr. Bertha Madras to discuss their work.
Next. So we started this study by asking some very simple questions. Is the use of one substance by adolescents associated with increased risk for using any other substance, regardless of the sequence by which they introduce the drug? And the second question is not using one substance associated with decreased risk for using other substances? In other words, question 2 is the inverse of question 1. Next. Next. So our study was published in Preventive Medicine. It was based on data from the 2014 National Survey on Drug Use and Health that is produced by Substance Abuse and Mental Health Services Administration. It scrutinized, surveyed a nationally representative sample of 17,000 youth who are aged 12 to 17. And these surveys conducted descriptive analysis and applied multivariable logistic regression models to control for age, sex, race, ethnicity. Next. What was measured? Lifetime use and past month use. What drugs were measured? Alcohol, binge drinking, which is defined as 5 or more drinks on one occasion. Heavy alcohol use, which is defined as 5 or more episodes of binge drinking in 1 month. Cigarette use, marijuana use, or use of illicit drugs other than marijuana. Next.
So this is Caroline DuPont, and I'm going to take you through some of the data from this. I'm very excited to share this with you. Next. So this slide, I just want to walk you through it so we're all looking at the same thing. You can see teen marijuana use is associated with higher use of other drugs. And so this is divided into two sides. One side says no past month marijuana use, and the other one says yes past month marijuana use. So again, as Dr. Madras said, this is for teens aged 12 to 17. So next slide. If you see here in the red column, you can see that in the group that said no past month marijuana use, their use of alcohol is also quite low, 8%. And if you say yes past marijuana use, there's 5.6 times more likely to have used alcohol, with an increase to 44.6%. Next. This holds true when you look at these other columns, and I'm going to go through this quickly, but you can see the light blue is binge alcohol use, rising 7.9 times higher for people who use marijuana in the past month versus those that don't. Next. This is the heavy alcohol use group, again, with a significant increase. Next. So here with the purple, we're looking at cigarettes. And in our modern era, we would love to be talking about nicotine, but we are talking about cigarettes from the research data here. And so again, you can see that for students 12 to 17 who haven't used marijuana in the past month, they're also very unlikely to have smoked cigarettes. But that number increases considerably, 8.9 times more to 23.6% in the group that have used marijuana in the past month. Next. So in our last column, we have other illicit drugs, and this could be opiates or amphetamines or anything else. But we see this same pattern once again, that marijuana use is associated with the use of other illicit drugs. So these slides that I've just gone through are showing, thinking first about that marijuana use. But when we come to the next slide, next, we're going to see that their same pattern is true for alcohol use. Go to the next slide. So in this next slide, we have the same situation. These are the same setup that we had before. On one side, we have no past month alcohol use. And on the other side, we have yes past month alcohol use. It's divided into 3 sections on that side: some alcohol use, binge drinking, and heavy alcohol use. Because we know in this age group, 12 to 17, that there is unfortunately a lot of binge and heavy alcohol use going on with that. So, okay, let's go to the next slide. Thank you. So in this, again, pointing to the green, so when you're looking at these students who said they have not used any alcohol in the past month, their use of marijuana is correspondingly very low, only 3.5% saying that they used marijuana in the past month. But if they said yes, they used alcohol in the past month, their use of alcohol is up in each of these different categories. So for the people who use some alcohol, it rises to 20%, in binge drinking, 34.3%, and in heavy alcohol use up all the way to 54%. And so I love these slides because they're so visual. It's so easy to see the comparison between the no use of the substance and the use of the substance. Let's go to the next slide. So again, the same thing we're seeing with no use, very low use of other illicit drugs, and correspondingly higher use in all the other categories for alcohol use. Next slide. And so this is correlating the alcohol use with cigarettes. Same thing again. And then I'm looking at the little purple line, very small with no use and considerably higher, going all the way up to 33.5%, a 13.4 times greater risk with the heavy alcohol users, but significantly greater in all categories. Now, we're going to do this one more time. Let's go to the next slide. And we're going to see that this association is again true for cigarettes. So let's look at that. We can go through it pretty quickly because your eyes are pretty used to this now. So again, no past month cigarette use on one side, yes past month cigarette use on the other side. You already know what we're looking for. We're looking for that big change. Thank you. We're seeing that big increase of alcohol, 4.2 times more likely to use alcohol. Keep going. Next. 6.1 times more likely to binge drink. Next. 10.4 times more likely to report heavy alcohol use. Next. And 7 times more likely to use marijuana. And last one, 7.7 more times likely to use illicit drugs. So these visuals really show the correlation between the use of one of these substances and the use of the other substances. Let's go to the next slide. So those slides we were showing were for past month use, but as Dr. Madras said, this study looked at both a past month and at lifetime use. And what you will see is the lifetime use of any one substance, alcohol, cigarettes, or marijuana, significantly increases the likelihood of using the other 2 substances or illicit drugs. So, and then the converse is true. Lifetime non-use of any one substance significantly decreases the likelihood of using other substances. So substance use is all related in this age group. So these are some of the study limitations. This data set does not include youths who are homeless, living in shelters or in institutions. It doesn't identify the use of e-cigarettes, obviously something we're all very interested in today. And our study cannot establish temporal causal relationships. And this is, of course, a self-reported study. Next.
So what have we learned? We have to recognize that we don't know if alcohol, cigarettes, or marijuana primes the youth to seek and consume other substances. In other words, does it change the brain in a way that they are very eager to find and to use all sorts of drugs? But what we do know is that the choice of either using or not using marijuana serves as a marker for an elevated risk of using alcohol in a binge way or heavily, for cigarette smoking, and for consuming other illicit drugs. What the study provides is strong evidence that there is a generalized risk for any substances consumed by youth based on the use of any one of the three most common drugs: marijuana, alcohol, and cigarettes. Next. What we have to recognize is that substance use is an important consideration for youth drug prevention, because for all teens, substance use is related. It underscores the critical need for screening youth for all substances. And if a single screening question that asks on the use of tobacco or alcohol, a positive screen for one substance in an adolescent should routinely trigger screening for an array of substances. That means that if the question is, when was the last time you smoked? Or when was the last time you had alcohol or engaged in binge drinking, that should trigger an array of questions on all substances. Next. We know that substance use disorders are pediatric onset diseases for most substances. 9 out of 10 adults, about 90%, begin substance use disorders by smoking, drinking, or using other drugs before the age of 18. The earlier and heavier the use, the more likely a person will develop later problems with these substances. Next. We know that the teen brain is not fully developed, even though sometimes it seems as if it is when they have answers to every parent's concern. But rapid brain development occurs between the age of 12 and even past the age of 20. It is thought that perhaps 25 or even higher ages are when the brain stops developing. And these MRI images show that the brain is increasing in size according to red codes, less so in yellow codes, and parts of the brain, the frontal cortex, which is by far the most critical part of the brain for judgment, for impulse control, develops very slowly until past the age of 20. And parts of the brain, in fact, are losing nerve cells, other parts are gaining them. Next. All substances put adolescents at risk. Early initiation and continued substance use significantly increases the risks of problems related to physical health, mental health, serious injury from death or accidents, becoming a victim of violence or sexual assault, reducing academic achievement, and also creating a risk for dropping out of high school and college. Next.
This is Dr. Robert DuPont joining. I'm very proud to be here with my co-presenters in this presentation. We have developed the concept of one choice of whether to use or not to use drugs. And we focused on a clear message that contrasts with the generally ambiguous messages such as drug-free, by being very specific about what we mean by drug-free, and by also the concept of youth. What do we mean by youth? So our choice of the words is one choice, and here it is. And I want to say it slowly so you can hear this, because it's very important to get the exact wordings here, the concept behind it. The health goal for young people is no use of any alcohol, any nicotine, any marijuana, or other drugs for reasons of health for youth under 21. That's complicated, but it's important to be clear about it, because much of the discussion about youth substance use is not clear. And so we're very interested in clarifying that message and focusing. This is not a prevention program, but it's a health standard that can be used by all prevention programs. And it's a refocus on what that message is. Next slide. Now, it can be a little alien when you hear that at first, but I want to compare it and contrast it with other simple messages, the health message that we have. We have a message that is always use a seatbelt. If you're in a vehicle, you wear a seatbelt. We don't say sometimes, we don't say when it's dark out or you're driving fast or whatever. We say always use a seatbelt. And similarly, we have a health message about always wearing a bike helmet. And we don't have any trouble saying unambiguously, avoid sugary drinks or exercise regularly. Those are common health standards that we say. Does that mean that we don't respect a young person or anybody who doesn't wear a seatbelt, or we don't respect somebody who doesn't wear a bicycle helmet? No, but it does say that that is the health standard. Next slide. Now, I'm going to focus on the seatbelt example for a moment with you to think about seatbelts and that message, always wear a seatbelt. When it comes to drugs, we normalize youth experimentation with drugs, and we take that as a given. Young people experiment with drugs. That's just an accepted way of thinking about things. People think about kids, have that as the idea that that's normal. Now let's think about seatbelts. Let's say we used that same approach to seatbelts, and we said it's appropriate or reasonable for youth to experiment with wearing seatbelts. What do you think would happen if youth experimented with wearing seatbelts? Well, I can tell you what would happen. They would notice that nothing bad happened to them. And they would also notice that their peers who were not wearing seatbelts also didn't have anything bad happening to them. And would we think that was a good message to kids to say, to youth, to say, experiment with wearing seatbelts and decide for yourself? We wouldn't say that because it would be thought of as being irresponsible to do that. And yet that's exactly what happens with the assumptions about drug use. So I want you to think about that again, that issue of seatbelts and how we're so clear about it, whereas we are very unclear about the drug use. So next slide, please. The thing that's striking to me is why we have this experimentation as a normal for drugs, and we don't with other health behaviors. And I think that's not just a mistake, but that's a mistake that encourages this experimentation with drugs in a way that's contrary to the issue, the health interest of the young person. Also point out that all teen drug use is illegal, and it's illegal for a good health reasons. And it's also quite striking to me that the alcohol industry, the nicotine industry, both the vaping and the cigarettes, consciously, directly say they don't want kids using their substances. The marijuana industry, the legal marijuana industry, also uses that. So we're not talking about, this discussion is not about adult use of substances. It's about youth using substances. And when we make that distinction, a lot of the controversy goes away. There isn't any good reason. There's no industrial or commercial reason that's legitimate for promotion of youth use of alcohol, nicotine, or marijuana. Next slide. But behind this discussion is the question of, is that realistic? Isn't it normal, expected, that kids are going to use, youth are going to use drugs? Well, I'm going to show you some data that's going to, I hope, be very helpful to you in answering that question. Next slide. Start off with me with looking at the blue line at the bottom. This is from the Monitoring the Future study, the way the country studies drug use by youth in schools. It's been started since 1976. It's a very important study. I was the White House drug czar when we started this. I recruited Lloyd Johnston to do this study, and I'm very proud of my contribution to this. It's a wonderful study for the country. But go back and look at the on the left side, and you'll see that the percentage of American high school seniors who in their lifetimes had never used any marijuana, any alcohol, any cigarettes, or any other illicit drugs was very low. The lowest point was in 1982, where it was 3%. In other words, 97% of high school seniors in 1982 had used at least one of those drugs at least once in their lifetimes. Now look at the most recent data we had at the time we did the study. It was 2014. It's 26%. Think about that. 26% of American high school students have never used any cigarettes, any marijuana, any alcohol, or any other drugs in their lifetimes. That is a steady rise that has gone on over 3 decades in the United States. Now that's lifetime. Now let's look at the orange line. This is no use of any drug, any alcohol, any cigarettes, any marijuana, or other drugs in the past month. And that was the low also at that same point, 1982. And you'll notice that now the number, the most recent one, 2014, is 52%. The majority of high school students have not used any drug in the last 30 days. And again, you see the steady change in that line over that period of time. Next. Now this just adds to we got lifetime on the left and past month on the right, and it adds, starting in 1992, the Monitoring the Future study added 10th grade and 8th grade to looking at, and you see those, and I see the same trend line going on in those, but obviously higher levels of no use in the 8th grade and the 10th grade than in the 12th grade. But this data shows that those same trends are going on in the 8th and 10th grade over the same time course. Next slide. I want to emphasize again that drug prevention is not about this drug or that drug. It's about any drug use at all. It's not about particular settings. It's not about driving and drinking, for example. It's about drinking. It's about any alcohol use. That's what the prevention is about. Now there's room for other goals too, but the overarching prevention goal is no use of any drug. And the earlier this message starts, the more successful it is, the easier it is to communicate that. And it's very important this message be repeated all through the community. Get parents involved in it, get educators involved in it, get pediatricians involved, other people who are interested in youth health to get involved in these messages as well. Next slide. Now this is a little complicated, and so I want you to just take a deep breath and look at just at the alcohol number. This is the percentage of high school seniors, 1976 to 2017, who have used alcohol in the past month. And you'll notice it was over 70% in the late 1970s. You see that number there? Now, look where it is now. It's just above 30%. I think most people in this country do not realize that dramatic drop in alcohol use that has gone on in the country over this period of time. The rise of the people who have not used, the fall of the people who have used, but that trend is very important and very striking. Now I want to contrast that number with looking at cigarettes. And you'll see there that also that went down, and Bertha was talking about this, from about 40% to now at 10%. That's a very dramatic change. But if you'll notice, it didn't go down very much until 1997, and then the bottom fell out. That's when the Truth Campaign started and the tobacco settlement happened. It was a very dramatic public health success. Now, and you see the general trends that all of them are down, including marijuana. Even now, it's down compared to what it was in 1978. But go to the next slide. Now I want to look a little more closely at the marijuana numbers. This is the green number. I didn't talk much about that. But you'll notice it has a different shape. It's generally down also, but it's a different shape than the other ones. You had a very dramatic fall between 1978 and 1992. In that 14-year period, marijuana use in this country dropped 62%. That was a major, major public health achievement that went on. It's often talked about in terms of Just Say No and Nancy Reagan. The reality is that started 3 years before Ronald Reagan was elected president. Nancy Reagan picked it up, but it was what's called the parents' movement. And I was very much involved in that at the time, and it was very dramatic, and it focused on marijuana. And you'll notice how different the marijuana number is and how dramatic it was over that period of time. When people say Just Say No didn't work, look again at that number and see what we've got here. Okay, next slide. But unlike the other numbers, after 1992, marijuana is up. You see it come up right dramatically, and then it's been more or less level since a little before 2000, the late 1990s. But it's on a different trajectory than the other drugs. It's level over this period of time, where alcohol and cigarettes are down in this. And look at marijuana crossed cigarettes in 2008. And if you project out the green line and the red line, you'll see that marijuana is on a trajectory to pass alcohol within the next few years. That was the marijuana legalization movement, which has gone on from 92 to the present. And it has changed the structure of that curve very dramatically. Okay, next slide.
Yes, this is Bertha Madras taking over at this point. What is the take-home message from this series of trends amongst youth? The most important one is that certain messages on certain substances. Can we go back to the previous slide? Can we go back to the previous slide? Thank you. The message is that certain substances like alcohol and cigarettes, these messages are getting through to young people. And it is clear that prevention works. Prevention is possible if you have a very concerted campaign where the majority of parents and communities are on board. The steady decline is not parallel to marijuana and to some other drugs. So what some people say is, well, one drug is substituting for another, but that doesn't seem to be a valid assumption. None of the other drugs had an uptick relative to marijuana. The only reason marijuana has increased is because of a heavy campaign to project its safety. Now, before we go on to the next series of slides, I would like you to just focus on cigarettes one more time. Cigarette smoking in 1975 amongst high school seniors, about 40% used in the past month, little under 40%. And that plummeted by 2015 and even more so more recently to little under 10%. Hold that thought for a moment. The next slide asks a very simple question. What's next for prevention? And because we are in an era of vaping, we cannot ignore vaping, even though it lies outside the dimensions of the manuscript and the research that we began to report. So on the next slide, we will do a subroutine, a subsection on smoking and vaping. And if you go on to the next slide, we'll ask a very simple question. What is vaping? It's use of an electronic device, an electronic nicotine delivery system, electronic cigarettes or e-cigarettes, vaporizer or vapes, which can be in the form of vape pens, dab pens, other devices. And the purpose is to inhale substances that are vaporized as opposed to burned into a smoke form. What kind of substances can be inhaled? Nicotine, marijuana, THC, which is the active constituent of marijuana. It's the psychoactive, the one that causes all its adverse effects. THC concentrates, cannabidiol, synthetic cannabinoids, or flavorings and other substances. As you'll see on the next slide, Joules has made pods which have tremendous appeal to young people. Menthol, cucumber, creme brulee, fruit medley, cool mint, mango. These are flavors that young people enjoy, as well as classic tobacco and Virginia tobacco. And these pods have been inserted into, as you'll see on the next slide, little Joule type of vapor mechanisms, or even e-cigarettes and or vaping pods that resemble quite a bit a USB stick that many people use to store data electronically. But there also have been pods that have been filled with marijuana. So the question we ask is, why do adolescents use Joules? And you'll see on the next slide, there are a number of reasons. Curiosity, if you can, recreational use with friends, believe that vaping is healthier than smoking. They can disguise their use from parents, from teachers, and in schools because there is no odor and there's no smoke and the size is very small. But what has vaping become? Originally, it was promoted as a way to prevent people from smoking by substituting tobacco for nicotine in pods that would relieve them of the types of contaminants that smoke deliver to the lungs. But what's happened now in young people, in teenagers? Let's look at the next slide, because vaping is now a crisis amongst high school students. Nicotine vaping is now at 25% past month use of 12th graders. So we've gone from 10% of non-smokers, 10% of smokers, up to 25%. We've more than doubled the number of 12th graders who have delivered nicotine into their blood and brain in the past month. And in 10th graders, it's almost as high. And in 8th graders that are about 13 years old, 9% are vaping nicotine. And on the right column, you can see that a significant number have started to vape marijuana. That's a problem because if you look, and if you go to the next slide, you can see what the trend lines are, that vaping has increased dramatically in the past 3 years. Just the past 3 years, we have seen a rise that is almost unprecedented in drug use. The Surgeon General declared that e-cigarette vaping among adolescents is an epidemic. And the former United States FDA commissioner has stated that e-cigarettes pose an existential threat to youth, called for exploration of drug therapies to help adolescents overcome addiction. And on the next slide, you'll see what the current crisis is, and then we'll go back to adolescents in a moment, because this was unanticipated by the FDA, by the industry, that we now have a new disease called EVALI, e-vaping associated lung injuries. We now have, and I'll update these numbers very quickly, 49 states now, including DC and the US territories. We have 33 confirmed deaths in 24 states. The population affected is close to 1,500 now. This was 2 weeks ago, and last week it's been updated, and there is a rapid rise in the number of people who have the lung injury. Most of the origins are in THC products, products that contain the psychoactive constituent of marijuana, and THC plays a major role in this outbreak. The demographics are that most are males, 80% are under 35 years. It's now 36% under the age of 21. And so many young people, 16% under the age of 18 years. What are the symptoms of the lung injury? You'll see them in the next slide. Some of them are indistinguishable from a severe lung illness and a lung infection, like pneumonia. There's cough, shortness of breath, chest pain, nausea, vomiting, diarrhea. That doesn't come along normally with pneumonia, but in this case it does. There's fatigue, fever, abdominal pain. Some have reported symptoms that develop over a few days. Some report symptoms over several weeks. And lung infection is not the cause of the symptoms. It's lung injury due to substances that accumulated in the lung due to vaping. Now we'll bring it back to adolescence. What is our concern with adolescents? In addition to the lung injury problem, e-cigarette use is 3 to 4 times the risk for starting to use marijuana. That means if a child uses a mango-flavored e-cigarette, and if you can just click on the button here, if they've never used cigarettes, they're much more likely to initiate marijuana. If they've never used cigarettes, they're much less likely to initiate marijuana or use marijuana than if they have, if they start e-cigarettes for flavors and for mango or creme brulee. Next, if you can click on the next, please. The risk is much greater for starting and using marijuana. Hookah use, which is another type of vaping, increases the risk of starting marijuana use. Adolescent dependence on nicotine and marijuana or cannabis. Vaping increases the risk of both. And federal regulations have not restricted youth-targeted advertising, promotion, or sales of youth-friendly vapors. So let's go on to the next slide. What are the final thoughts for prevention leaders? For teens, all substance use is related. Prevention is the best hope. We can treat and we must treat, but if we don't stop the pipeline to addiction, it will be a never-ending public health challenge that will face families, communities, and society for a very long time. We have to consider that preventing drug use is a form of protecting our brain. That is the repository of our humanity. What can you do? Denormalize youth drug use. Normalize no drug use by youth for brain health. Thank you.
Bertha, let me jump in here for just a minute before we get to the questions and think with everybody about some additional final thoughts. What Bertha has, Dr. Madras has brought up here about vaping is extremely important. The same thing is true right now about fentanyl, which is changing the way we think about opioids. The looking at the drug issues, drug by drug, misses the general pattern that is going on. And one of the key ideas we have here is it's use or not use. And once there's use, there are literally hundreds of drugs. And the drug production industry is coming up with more drugs, more different ways of doing it all the time. So what I think about it is this is commercialized recreational pharmacology. It's using chemicals that super stimulate brain reward for pleasure. And they are commercially promoted, both legally and illegally. And the key to dealing with the epidemic generally is in youth. It's what happens to youth, because that is the major point of vulnerability. So when you look at the whole issue of the drug problem in the country, you're looking at the use of chemicals that stimulate brain reward for pleasure. They are commercially promoted, and the goal is to reduce the use in youth. And the key to that is this single standard, which is the standard of no use. And what we've shown is, in this data, including the vaping data, which Dr. Madras showed at the end, that whether you use e-cigarettes or don't, predicts the use of other drugs also. So, and that's true for all the drugs. They're all interrelated. The use of any of them increases the risk of all of them. So that is really an important message. And we go back to that simple standard for health. Doesn't mean you don't respect people who don't have that standard, but that is the standard. And it's standard for people who already started to use. They can stop at any time. It's not something that if you start, you have to keep using. No, you can stop. And the standard for people who have kids, youth who have used, is also to stop. It's the same standard for them, whether they used or haven't used. And that is for brain health, no use of alcohol, no use of nicotine, no use of marijuana for people under the age of 21. That's the key idea. And as Bertha said at the end, the normalization of drug use is the problem. So we want to denormalize it. And we want to normalize the trend that is already happening. It's not, we don't have to create the trend, it's there. And what we want to do now is recognize that trend and build on it. And I appreciate CADCA for this opportunity for the three of us to present this.
Thank you. We're now going to move into the question and answer session. So first, CADCA will ask Dr. Robert DuPont, Dr. Caroline DuPont, and Dr. Bertha Madras several questions, and then we'll turn it over to participants to ask their own questions. So if you have a question for the presenters about their research, please go ahead and type it in the question and answer box. And that's that box with the Q on it. It's not the chat. The chat is the little speech bubble. And I see some of you have already put some questions in there, so thank you, but everyone is welcome to add their own questions. And I'm launching a poll right now, so if you would like, you can answer this quick poll about topics for upcoming webinars. I'd love to get your feedback about what you're interested in hearing about in this webinar series. And then also, one more thing about the question and answer box. If you see another question someone's typed and you're interested in hearing about that, you can upvote it. So let's get started with the questions. In your study, you looked at youth use of marijuana, alcohol, cigarettes, and illicit drugs. How does prescription drug use fit into your study's findings about generalized risk of substance use?
Bertha, you want to take that?
Well, we actually received data that was widely publicized by the director of SAMHSA, Dr. Eleanor McCants-Katz, showing that youth marijuana use increases the risk, is associated with approximately 8 to 10 times higher risk for misusing opioids. And opioids would imply heroin plus prescription opioids. The association is also true for 18 to 25-year-olds. It's a little bit lower than for adolescents, but it's still quite robust. So I think we have to assume that this extrapolates to the opioids as well.
Yeah, I would just add, this is the general principle that we have, and I hope you're taking away from this webinar, that the use of any drug is positively correlated with the use of all other drugs because of the generalizability of this behavior.
All right, for the second question, the increase in youth e-cigarette use is a crucial issue for coalitions to address. How can coalitions use the findings of your study to target e-cigarette use in their communities?
Bertha, again, you want to take that?
Well, I think the most important thing is to understand that there's been a great deal of misinformation on e-cigarettes. As I said, they were originally promoted and presented to the Food and Drug Administration as a way to stop smoking cigarettes. After that, without regulation, and starting around 2009, companies, including very legitimate companies, meaning companies like Juul that made the e-vaping cigarettes, began to create pods with just flavors in them. As I said, mango and vanilla and creme brulee. And from my perspective, that was a way to seduce young people into using vaping as a method of delivery and as a form of habit making. I think that what's critical now is that you should present the new data that says that young people who start with e-vaping are much more likely to put nicotine into those pods, to use nicotine, and we're reversing all the smoking cessation we had. But it's even worse than that. We'll talk about smoking first and marijuana second. What's happening is that there is a reasonably high rate of conversion of e-cigarette use to cigarette smoking. And that's just entering into research studies now. So that the gateway starts from creme brulee pods, sweet, fruity flavored pods, to nicotine, and then to smoking. But also once they start with nicotine, there's also a risk of starting marijuana. And right now, the highest number of cases, about over 75% of the cases that are involved in lung injury, this terrible disease that has affected 49 out of our 50 states, that injury is attributable mostly to THC, to marijuana products. So these are the messages one has to take forward. And the slides that you have seen today should be used to promote these messages. And I fear that as time goes on, things will get worse amongst young people because, as I said, it's much easier to conceal vaping compared with cigarettes. It's much easier to conceal the odor of marijuana with vaping than it is with cigarettes. And it gives rise to less oversight amongst parents, amongst teachers, in schools, in environments that are designed to protect young people.
So I'm going to jump into the audience questions since there are some follow-up questions about vaping, but I'll come back to the other questions from CADCA. First, I think I heard you mention the answer to this already, but Sandra has asked, can we use some of the slides on vaping? It's really good information. We've had many parents and teachers asking about this issue.
Of course.
All right, second question about vaping. From Diana Hendricks. Is there a projection of youth vaping reduction since policy is banning jouling companies from selling joule flavors? And is there concern youth will return to cigarette smoking?
Well, from my perspective, I don't know what these survey data on youth are conducted annually. So the new Monitoring the Future studies will be coming out in a month or two. They usually come out in December. We'll be able to see if there's any change whatsoever, but we'll have to wait. That's number one. Number two is that people who have developed addiction to nicotine through e-vaping, and one has to remember that the nicotine content in these vaping pods is very high. And the higher the dose, sometimes the more rapid the addiction. It may be that we're going to see a transition to cigarettes among those youth that have started with vaping. We're already seeing it in some adult populations that started with nicotine vaping and now are transitioning to cigarettes. It is possible that this will happen as well in youth. And that's one of the great dangers of vaping, is reversing this wonderful change, 400% drop from 40 to 10, 4 times, that we've seen in our nation. It was a tremendous public health accomplishment, which has the potential of going all the way in reverse because of vaping.
I just want to bring up briefly about changing the way a drug is delivered, the way people take the drug. There's a long history of that increasing the use of the drug. And so when you went from chewing tobacco to smoking the tobacco, or you distilled alcohol into stronger concentrations, or you changed from cocaine to crack, or you changed, in this case, from smoked tobacco to vaped tobacco, you get a whole new audience. And what we have now is not only the brain biology that jumps on that the same way it has through history, but we also have big business that is looking for new and creative ways to separate people from their money. And so when you're in prevention, one of the things that we has a caution against is being too specific about don't do this one item, because there's always a creative new chemical coming out or a new delivery device coming out that's going to change the game. And that's one of the reasons that, especially for primary prevention, we would like to focus on the no use of any of these substances rather than being substance specific.
Yeah.
Well, that's a great segue into my next question from CADCA. CADCA encourages coalitions to pursue environmental strategies in order to prevent youth substance use. You mentioned that clear and consistent prevention messaging is an important strategy based on your study. Do you have additional strategy suggestions for coalitions, particularly environmental strategies?
I'd like to jump in on that one, Carolina. the environmental strategies are good strategies. Youth who have good relationships with their parents are less likely to use drugs. Youth who have a grounding in their identity and are responsible citizens have less drug use than other kids. So anything you do to help kids is going to reduce the drug use, and being helping kids grow up healthy and do healthy things is a wonderful thing, but it still is not specific. And I ask you to think about, good as the environmental strategy is, think about seatbelts. Seatbelt wearing is also correlated with exactly those same factors. All those factors that are associated with youth not using drugs are also correlated with youth using seatbelts. Would you think a smart strategy for dealing with seatbelt use would not mention seatbelts, would not say specifically wear a seatbelt every time? And I think you see, when you think about the seatbelt analogy, that an environmental approach is a good approach, but it isn't the whole story. You have to go the next step and say in words what you mean. You mean every time you get in a vehicle, you wear a seatbelt for health. Not disrespecting anybody by saying that, but we're having a clear health standard. I think that so I'm in favor of all the environmental strategies, but I want to add to them a specific statement, not about a specific drug or a specific route of administration, but about the use of any drug is unhealthy for youth. That's what I'm hoping will come out of this meeting, this session, this webinar.
And then I'd like to add in also one more thing, and that is that the messaging is really important, but we think the data is really important, and that the youth really thrive on data. They want to see the slides about brain development and see that their brain still has a lot of developing to do, and think about brain protection. What can they do to protect their health? What they do to protect their mental health? What they can do to protect their education? And so giving them these slides and also showing that they have a lot of company in not using, because it can seem like everybody's using, the way our culture kind of glorifies use. And so if you can get those people who are not using to stand up as leaders in the community and tell people why they are not using and what their no use story is and what it is that why they've made that choice and what they're doing with that choice, that's really powerful. So I think that occasionally we have people say, you have so many graphs and so much data, can't you just say it? Yes, but if you show the graphs and the data, people understand that you're not giving them a lecture. You're actually helping them, give them the tools to protect their health.
Yeah. Excellent point. There's a question by Philip Drum that I would love to address just very quickly, and that is, does MTF truly capture all students? And he's aware of legal marijuana states that refuse certain national student surveys, and certain studies do not include students that have been expelled for drug use. I think that that's a really important question, and I think that we have 3 surveys that address youth. One is the Monitoring the Future, the other is the National Survey on Drug Use and Health, and the third is Youth Behavioral Risk Survey done by the CDC. So 3 federal agencies do their independent. In general, they do agree with each other, but the most important issue is that they cannot capture some kids. They cannot capture children who refuse to answer the questions, and there may be a direct correlation between refusal to answer and substance use. They may not capture students. MTF does not capture students who are not in school, but the National Survey will capture households, which could be shelters as well. but young people who are homeless, who are transients, they don't capture those. And from my perspective, they may be the ones who need the most attention and the most data gathering.
All right. Julie had a question that I felt related to the question that Dr. Robert DuPont and Dr. Caroline DuPont were just answering. So I'm going to circle back to that. She said, do you intend for the one choice message to be shared with adults or youth? If youth are an intended audience, have you developed youth audience tested awareness campaign or education materials?
Oh, that's a great question. So we are intending this message to be shared with anybody. So we do direct this directly to youth, but also to parents and educators and medical personnel who would interact with youth, because we really are working on making this health standard. But we have been partnering with a wonderful prevention organization in New York. They're in Rye, New York, and they have been using our one choice messaging in their education programs now for the past several years, and have really developed some wonderful ways to integrate this into their prevention program. So for example, they have taken our phrase, we say one choice, and they have turned that to say, I am one. And so they have made like Post-it notes that are colorful Post-it notes that say in a text bubble, I am one, and then you write why you choose to be drug-free. And so the students are able to write in their own words why they are one, and then they can stick them on a board that they have displayed there in the school, and then they take it, that's a high school that does this, but then they take it to the middle school to show the middle schools how they are making this one choice. And then they have a video that they've made that says, I am one, and the students say, I am one, I make the choice to be drug-free because, and then again, they're explaining why they've made that choice. And I love this because it's putting a face, and it's also putting a meaning behind making this these decisions, and also showing again what I call that 26%, that percentage of high school seniors who are not using and who have never in their lifetime used. And they're such a powerful group, and they usually fly under the radar unless they're given a platform. And so a prevention organization is really in a perfect position to give those people that are already naturalistically, in fact, making this choice, a voice and being able to be leaders in that.
I would like to pick up on that also and go back to my analogy about seatbelts. We know that many people, let's just think about youth for a moment because that's where we're talking, many young people can do just fine without wearing seatbelts. Nothing bad happens to them, and that's fine. So we can't say that if you don't wear a seatbelt, bad things are going to happen to you. And that's the same thing with drugs. There are many young people who drink, smoke cigarettes, use marijuana and other drugs, and nothing bad happens to them. That is the case. Now, if you think about it, would you want to have the question was asked, where's the evidence that you can give this message and it's going to reduce use of drugs? And think about that with respect to seatbelts. Where is the evidence that having a standard that says wearing seatbelts is a good idea for health, that this is a health standard? You don't ask that question. We're not talking about a program. We're talking about a health standard for youth. It's very hard for me to imagine that anyone would think that the youth who don't use have better outcomes than the youth who do use on any basis. And every time that's been looked at, the data is very clear, and it shows also that the more drug use there is, the more negative outcomes. But that doesn't mean that everybody who uses has a negative outcome, or everybody who doesn't use has a good outcome. So I think, again, to me, it's a double standard on the health standard for drug use, that it's asked to meet a standard that other health messages are not asked to meet, where the evidence is clear that eating healthily or exercising is a good standard for people. To me, that's exactly the way this standard is, and it should meet exactly those same standards. And for those people who think the drug use is immutable by youth, you look at those trends of what's really happening, the growth of the no-use population, and that 62% drop in the marijuana use with the parents' movement. Those give you clear evidence that dramatic changes are possible in youth drug use.
Yeah, I would like that. That's excellent, Bob. There's one issue that I think hasn't been raised yet, dramatically, and that is the issue of parental influence on youth drug use. The NISDA data, I've been looking over their copious tables of thousands of numbers over the past few days, studying them in preparation for a presentation. And one thing that struck me dramatically was that Asian youth are by far the lowest users of drugs in our country, including marijuana and other substances. If you actually look at the questionnaire that says, do you think your parents would disapprove? Their parental disapproval ratings, which are well over 90%, are much higher than other parents. And I think that parents are one of the great untapped resources in trying to promote prevention and in taking the messages from this presentation and reducing it to practice. I think it's untapped. We talk about resilience. We talk about developing coping skills. We talk about high school biology lessons. We talk about all sorts of very important environments where young people can learn important health lessons. But somehow parents have been sidelined in this, and yet they seem to have an inordinate influence on what their children do. And I would suggest that some of the targeting is directly to parents. The other issue that has been raised in the questions that I've glanced at is, what about youth in trouble? And that's a very important question, because many young people are using drugs not to get high, but to sleep, to reduce anxiety, to reduce stress, all sorts of psychological reasons, which may stem from difficult environments at home or environments at school or in their social groups. And those kind of questions have to be addressed directly when counseling not to use any drugs.
I have a phrase that I've used a lot, and that is, there is no problem so bad that use of alcohol and other drugs won't make it worse.
Well, that's very true. The problem is that most people who are using do not have that message and have not absorbed that message.
That's because at the moment they use it, they do feel better.
Yes.
But the consequences of that downstream are negative. And that's why all the self-medication ideas are all ideas that whenever you hear that phrase self-medication, you're talking about a behavior that is unhealthy. You don't talk about self-medication with exercise or a proper diet. You see it with marijuana and alcohol and other drugs too. And that's because the drugs do, quote, work to diminish bad feelings in the short run. But down that road is a worsening of all of those symptoms.
Yes. Well, it's hard to imagine somebody self-medicating with a drug that can bring on a brain disease, but that is, in fact, the oxymoron of our times.
Well, because the short-term effects are they like the feelings.
Yeah.
All right, I'm going to jump right in here because we are running out of time. I'm going to ask you one more question, so please give a brief response to it. And thank you to everyone who asked questions that didn't get answered and that did get answered. They were all great questions. It was hard to choose. Last question. Where can interested coalition members find more information about your work? And what other resources can you recommend for coalitions interested in youth polysubstance use?
Well, we welcome them at the IBH website, ibhinc.org. And I hope that lots of you will go to that. And what's the prevention site, Caroline?
onechoiceprevention.org.
All right, we did go through some questions for participants. So before we wrap up, I have a few announcements. The next webinar in this series will be held in December of this year or in January 2020, and a topic has not been set yet, but I will take all of your poll answers into consideration. And if you have longer thoughts about the topic, you can send me an email. If you would like a letter of participation for this webinar for continuing education, please send me an email at kduth@cadca.org, and I'm writing that in the chat box right now. So that's kduth@cadca.org, and I will also distribute the slides following this webinar to everyone who participated, and I will post the recording and the resources mentioned in the question and answer session on the CADCA website in the next week or so. Thank you to Dr. Robert DuPont, Dr. Caroline DuPont, and Dr. Bertha Madras for their wonderful presentation on their work and for their tireless work in providing relevant and current material. And we're also excited that they'll be joining us at Forum. So if you haven't heard enough from them right now, if you come to Forum, you'll be able to hear more. And as I mentioned earlier, thank you to all the webinar participants for your comments and your questions and your insights.